My name is Dr. Juita. As soon as possible, we will finish this one, this topic. So the lecture is very comprised, it's sort of very concise, and just a general overview of good clinical evaluation of GI system. Yeah? If you want to know more, you have to, go back and read some more, and it comes also with experience. So at your stage, you have to, at this point of time, you have to bear in mind that you have to correlate whatever you learn from pre-medical, all the basic sciences knowledges, and apply that into your clinical materials later on. Alright? Okay, so my outline today is how to examine patients with the GI system. Let's say when you come into year 3 next year. So what do we expect from you? Okay, what are the GI system examination comprised of? And then the major science symptoms of GI system, presentation of GI disorders, approach to interpretation of liver enzymes. I'm sure you are quite knowledgeable in this, because it covers all your basic physio, pathophysio things. So just go back, and it's just a recap of your basic sciences. Okay, and then just a general overview of viral hepatitis, liver cirrhosis, fourth hypertension, upper GI bleeding, diarrhea, a little bit on diarrhea, as well as colorectal cancer. Alright. So when we want you to examine, can you just take down the lights? Yeah, the front one. When we ask you to examine the patients with a gastrointestinal system, okay, let's say we have a patient with ascites, examine this patient's abdominal system or gastrointestinal system. Okay, you don't go straight to the abdomen. Okay, first of all, system is you look at the patient as a holistic manner. Yeah, look at the patient's general overview. How's the mental status of the patient? Whether the patient is alert and conscious, was the patient in shock, in respiratory distress, or clinically obvious jaundice, any stigmata, obvious stigmata that you can notice of. All right. And then after that, you get to the peripheral clues. Look at the patient's peripheries. Look at the vital signs of the patients, what the blood pressure, what the pulse rates, any marks, any tattoos. things like that, and then go to the face, neck, as well as the proper abdominal examination. Not go straight to the abdominal examination. That is not acceptable. Okay, so after that, okay, just a recap, your surface anatomy. So there are 9 regions for you to palpate, for you to examine, for you to palpate and examine these patients. Okay, begin with on the right side, RHC, right hypochondriac region, epigastric region, left hypochondriac. I'm sure you know this. Right lumbar, umbilical region, lumbar region, right iliac fossa, pubic region, as well as the left iliac fossa. You go systematically. Yeah, it doesn't matter whether you start from the left or the right or in a circle, but the most important thing is you have to cover all the areas. Okay, right, it's very important. Okay, there are some discrepancies between physicians as well as surgeons, patients. In certain techniques applied by physicians, they apply only in 4 quadrants. But physicians tend to do in more detailed palpations in the 9 quadrant regions, in 9 regions, rather than 4 quadrants. Okay. So why is this important? Because it tells us, it gives us a clue to what are the underlying abnormalities. If you have found a hepatosplenomegaly plus this patient is pot belly, so you can clinically correlate with these patients. Yeah, if you found a massive cervical neck lymphadenopathy, yeah, with hepatosplenomegaly, so you can deduce what a possible differential diagnosis this patient has. Okay, that's how it goes. Okay, the basic thing is examine this patient in supine position and adequately expose this patient. Okay, if you do not expose this patient, you do not get to see any scars, any veins, yeah, anything that you might be missed. Yeah, you might be missed by not exposing this patient enough. Okay, for a male patient, it doesn't matter. Alright, the aurat is from where? But this is rusakkan, the patient is sakit, so it should be no problem. So you by right, you should extend. For a male patient, you can expose the whole chest area, or from the nipple line to the mid-thigh region. But for the sake of the patient's modesty, sometimes because of the circumstances in our hospital, it's not really private, so you have to like take the curtains or the divider. Sometimes you just extend the patient's lower abdomen until the iliac region or the inguinal region. Okay, for the sake of the patient's modesty. But by right, ideally you should expose to mid-thigh. For female, yes. Okay, you can properly dress this patient. You can do like this. Yeah. Close the breast. Or you can get 2 separate sheets, separate sheets covering from the breast, exposing the abdomen as well as the closing the areas of the inguinal endowments. Okay, you can check the necessary. Okay, like I said, you don't go straight to the abdominal examination straight away. You look at the patient as a whole. Okay, look at the patient's general appearance, any stigmatas, peripheral clues that can help you along the way, as well as going straight to the abdominal examination. And abdominal examination, you know, as in other systems, it comprises of inspection, palpation, percussion, auscultation, as well as others. Sometimes you ballot the kidneys and things like that. The technique is slightly different from system to system. Okay? Okay, so what do you look for? Especially in patients with the GI system. So, how you look for icterus? You look at mainly at the sclera. Okay, right. You can ask. There are soft ways to do this. Yeah, whether you can use your both hands. Okay, both hands, both right and left. There are, certain examiners prefer only one-sided. You know, because they say if there's icterus, there's jaundice. Would you expect jaundice only happens in only one eye? It's not like a right eye conjunctivitis or things like that, kan? So it must involve both eyes. So the sign can be elicited only with either side. But certain traditional lecturers, they still prefer for you to do both eye examination. examination to check for sclera, jaundice. Okay, what else? You need to know if there's any spreading nearby, any dilatations, and then you check for the fetal hepatitis, especially in a patient with suspected chronic liver disease. So there will be a certain smell this patient will have, but this is not expected for you to do in all patients. Okay, right. So and then also look for stigmata of chronic liver disease, like ulnar erythema, and then look at the patient's finger. Look at, is there any digital clubbing? Okay, and then after the pale and the jaundice, and then you look at the neck and see any obvious mass and cervical lymph nodes or anything like that, any parotid glands, and then you check for the gynecomastia. That's also a stigmata of chronic liver disease. Okay, why? This underlying pathophysiology, you have to go back to your why you have a gynecomastia in a male patient with chronic liver disease. Okay, alright, this genesis. Okay, now after that you palpate for the hepatomegaly, splenomegaly here, and then check for the pedal edema here, and then after that you percuss, check for the sacral edema as well, the pedal edema, and then don't forget about I would like to complete my examination by checking for the parietal, checking for the inguinal region, as well as checking for the bedside test that you can do, bedside rapid test, like a urine test or things like that. And then look also for the patient's temperature chart and vital signs chart. Okay, this is how you approach your patient's clinical examinations with GI system. So, ulnar erythema, this is the more well defined than this picture. Okay, there are a few causes of ulnar erythema. One of it is chronic liver disease. Other causes? What are the other causes of ulnar erythema? What are the other causes of ulnar erythema? Pregnancy is one of it. What else? Thyrotoxicosis, sometimes they can have. Hyperdynamic state, they can also have ulnar erythema. So you go back and check why a certain patient have a certain signs. What are the disease indicate? It is not solely exclusively for chronic liver disease only. Okay, but it can help you along the way. Alright? Summer, what is this? This is the photonous contracture. A thickening of the fascia, especially in the middle finger. It's a sign of chronic liver disease, especially in the patients with alcoholic liver disease. Okay, you don't really see all these signs in all patients with chronic liver disease. But if you can note this, then that's good. It's a good sign of alcoholic, more specific of alcoholic liver disease. How about that? This is jaundice. Because this patient is fair, you can tell it straight away, isn't it? But what if the patient is dark colored, dark skin? Where else sclera? Where else you can see a jaundice? Nails, very bad one. Severe ones you can see in the nails, in the palms, as well as the soles. Okay, there. And then if there's a markedly, deeply jaundice, sometimes when the patient has presented when the patient is presenting with cholestatic jaundice, sometimes it's very deep jaundice, very yellow sclera. Sometimes it goes to the under the skin general. The abdomen also looks yellowish. Okay, those are the areas that you should look for jaundice. Okay, right. These are ascites. You know ascites here. Okay, this is how you look for jaundice. Okay, you ask the patient to look down and look for the sclera, and you ask the patient to look up to look for the pallor conjunctiva. All right. Leukonychia. What this sign is for? Leukonychia. Leukonychia is what? Whitish nail. What is a spoon-shaped nail? Koilonychia. So what does that signify? Iron deficiency anemia. Okay. There are certain nutritional deficiencies signs that you can see on the nails as well, like Bose lines, Terry's lines. Go back and read what are these signs are for. That's quite rare, but you should know all the common things, the common signs. Yeah. Digital clubbing is very important. You should look for and grade the clubbing. After that, after palpation, you should percuss. This is a technique to percuss yeah, especially for the spleen. Okay. After this method, if you cannot get any splenomegaly on palpation, you should percuss this way, extending from the right iliac fossa towards the left hypochondria. If you cannot feel any, you don't think there's any dullness on supine position, what you should do? There's a maneuver. So you should turn this patient to the right side and percuss the trop space. The trop space is comprising of 9th, 10, and 11 rib on the left side. If it's dull to you, so that means there's a degree of splenomegaly. Okay, why? Because the spleen is usually located more on the posterior side. If it's enlarged, you know, it just encroaches to the lateral side and going anteriorly. Okay, if it's truly enlarged, as in cases of massive splenomegaly, moderate to massive splenomegaly, sometimes you can feel the notch of the spleen. Okay, that one you should not miss. Should not miss moderate to massive splenomegaly. Okay, there are certain characteristics to distinguish whether this is a spleen or whether this is left kidney. Sama juga. Similarly, there is also a technique, certain characteristic to differentiate whether this is a hepatomegaly or whether this is right kidney enlargement. Okay, go back and wait. Okay. How about testing for ascites? Okay, we test ascites by two methods. For moderate ascites, we do the shifting dullness. Okay, how do you do a shifting dullness? So, let's say assume this patient is, okay, this patient is lying supine. So what do? Let's say you must always examine this patient from the right side. It is not acceptable, even if you're kidal, even if you're left-handed. Yeah? It's more appropriate for you to examine from the right side. And then the patient is in supine, adequately exposed. So you want to elicit for ascites. So how do you do? So let's say the umbilicus is here. Because of the massive ascites, the umbilicus is everted. Terkeluar. Alright? So what is meant by tympany and transition point and dullness? Okay, so it is just based on the gravity principle. Okay, when you lie supine, you know, because of the bowel lumen, so the bowel is filled with air, kan? Sometimes it goes up, and the water is distributed evenly, kan? According to the gravity. So, what do you expect? In supine position, let's say you percuss, you should percuss. You can percuss towards you, or you can percuss away from you. I would suggest percuss away from you, because why? You get to kill two birds with one stone. Why? Because when you percuss away from you, percuss, let's say you percuss, and then you found an area of dullness here. You should mark that area down. Okay, just mark mentally, ataupun just mark with a mild point. Yeah, then a pen or something like that. Yeah, let's say you percuss toward away from you. And the dullness area is here, right? And then you should turn these patients toward you. Turn these patients towards you. And then this is how it would look. Again, because of the fluid is dependent on gravity, it will distribute evenly. And then from here, just now dekat sini kan, the transition point was there, and now it becomes gravity dependent. It moves according to the gravity. So this is a positive shifting dullness. Okay, previously dull dekat sini. After that, once you remove, you move the patient, and the transition point differs. Okay, so a positive shifting dullness is elicited. So that means that the patient has a moderate ascites. Okay, so this test has about 80% sensitivity, but it's not specific. Okay, but clinically recognizable ascites, you can find, a positive shifting dullness when there's a presence of ascitic fluid within peritoneum, about 1 liter. So you can detect that by shifting dullness. If it's massive ascites, your peritoneum is great. It can store up to 10 liters, 12 liters of peritoneal fluid, massive, huge. Yeah. So this technique is not relevant. Yeah, you cannot do because of the massive ascites, it's distributed evenly. Every area is filled with the water. So what is the best thing to elicit for ascites? You know it's ascites, you want to confirm whether there's ascites or not, kan? So you do a fluid real test. Okay, presence of fluid trace. So you ask the patient or your assistant, your friend, to put a hand in the middle of the patient's abdomen, and you just flick one side of the patient's abdomen, and you can feel the vibration over there because it gets transmitted with the fluid. Okay, so that's a positive fluid trail. Right? And then you also have to know about the concept of transudative and exudative ascites. This is very, very, very important concept when you go to your clinical years later. Yeah, certain patients, when you do patient with ascites, by right we want to know what are the etiology. If it's not clear-cut chronic liver disease, the patient newly diagnosed, so we want to know whether is it because of infective, whether this is because of malignancy, whether this is because of chronic liver disease. Yeah. Apart from all the stigmata, sometimes the stigmata can occur hand in hand or simultaneously. So what do? You tap. You do a peritoneal tap, and from there you analyze the peritoneal fluid and check whether this is transudative or exudative. It has certain criteria. If exudative, it tells you something. If it's transudative, it tells you probably the origin is certain things. Okay? Alright. The presentation of patients with GI symptoms is varies. Yeah. In one small study, they just note that the most common presentation just patient with gastritis symptoms. Apart from that, there's also esophagitis. Yeah, this is from one clinic, but nearly it also can reflect the general, the GI clinic in the whole world. Yeah, what is the commonest symptoms that the patient has? Apart from the gastritis, sometimes they can also present with gastritis. Apart from that, there's also problem with hiatal hernia, hepatosplenomegaly, yeah, upper GI bleed, yeah, cholelithiasis, hepatitis, pancreatitis, as well as chronic diarrhea. Okay, symptoms may vary. Yeah, okay. Later on, I will just give you a brief combination. How are you going to deduce? Okay, let's say if the combination of this, what are the likely causes? Okay, but you have to know more. In order for you to know more, you have to know more of differential diagnosis possible. Alright? What if the patient is jaundice? So jaundice, you know something is wrong with the liver functions. Can especially what causes jaundice? Okay, bilirubin. Okay, so there are two components kan of bilirubin. I'm sure you are master at this kan. Whether this is conjugated or unconjugated hyperbilirubinemia. So, but conjugated and unconjugated hyperbilirubinemia carries a different significance. Sometimes both can be raised, but you look, when you interpret a liver enzyme, you have to scrutinize every abnormalities that the patient has. Yeah, don't simply ignore or just overlook a few things like from the total bilirubin, you just look at the direct bilirubin saja. You're just only interested in the direct bilirubin. You just ignore the unconjugated ones. So it's not right. So when you become a doctor, do not ignore every single thing. Okay? So you know if it's conjugated, what are the possible causes? Yeah, if it's unconjugated, what are the possible causes? And go back to your basic pathophysiology of disease. You know why it happens certain ways, right? And what its clinical indications. Okay. How do we, as physicians, know? Okay, what are the possible causes? Yeah? Just interpret the liver enzymes. Right? Look at the patient's. Let's say the total bilirubin is increased, more of direct ALP is increased, gamma GT is increased. Probably this patient has cholestatic jaundice. Okay, let's say this patient is a little bit jaundice, not too deep. But ALP is okay, mildly raised, not too bad. But the more of transaminitis, AST and ALT, so it could signify a few causes. Yeah, to us. This is why it's very important for you to know. Yeah, at this point of time, what are you learning? Kalau let's say you baca pathophysio, okay, kalau let's say what if only the ALP is increased, the AST, ALT normal, but the patient has anemia and hypercalcemia, so it might give you a different etiology altogether, right? This one will come with experience later on, okay? But the basic liver function test you need to know. Alright, so you know classifications of jaundice, whether pre, intra. Go through. And this is the summary. Okay, this is as a general guidelines, but in certain cases, yeah, it has a mixed picture. Yeah, sometimes in a very complicated cases, sometimes the case it's not as clear cut as this. Yeah, sometimes patient with leptospirosis infections, they can also have transaminitis, but the ALP is also markedly high. Yeah, so we cannot really say that this applies to all. There's nothing like 100% in medicine. Okay, so from age predisposition also you can see, as well as the liver enzymes and the clinical pictures of the patient. You know what are the possible etiologies, whether this is alcoholic, yeah, from the history, yeah, history, and do your physical examination, whether this is possible cancer, whether this is because of the drugs, or whether this is all from the metabolic inborn error of metabolism, or is it because of the obstruction or autoimmune disease. So there are so many causes of liver derangement. Okay. So the most important thing is for you to get the right history. Get a full entire history. I always stress my students. Okay, if you want to clot a patient, clot properly. Okay, because 70%, you know, about 70 to 80%, just by a very good history, you can formulate a differential diagnosis, and you don't need the investigations to confirm that. Okay, just by listening a good and detailed history, you can get at least about 2 or 3 differential diagnosis, which is good. Yeah. Okay. If you only can arrive to a single diagnosis at your initial evaluation, that means something is wrong with your history. Okay. After that, you do your physical examination and always complement your history with a few investigations to confirm whether betul ke tak, whether you can eliminate or include your differential diagnosis. Okay. Let's say from your patient's history, they can have a fever, nausea, anorexia, and then notice jaundice by family members. Okay, probably suggestive of viral hepatitis, or probably because of infectious causes. Kan, fever, abdominal pain, nausea, anorexia, and then noticed by jaundice, leptospirosis, malaria. It could be the causes apart from the viral hepatitis. So, based on your provisional diagnosis as well as your differential diagnosis, you pursue further. What are the next investigation plans that you want to pursue? Okay, bear in mind, there's nothing such as routine bloods in medicine. Okay, you have to focus. There's no point of you wandering in a non-relevant blood investigation. That is not helpful for you. Let's say this patient is fever, nausea, anorexia, and you want to do, let's say, what test? You want to do a urine test, which is not really relevant, isn't it? You want to confirm whether this patient is infectious, so you want to confirm malaria. So what do? You go to fake anything blood smears, kan? You look at the WBC, look at the evidence of leukocytosis or leukopenia. Both can suggest infections as well, kan? And then look at the liver enzyme, whether to see what are the degree of transaminitis that this patient has, what are the degree of cholestasis that this patient has. So this is how you should work. Prioritize your investigations. Okay, there's no point. The fever, nausea, anorexia, you straight away send this patient for MRI. What for? Okay, the basic things, the most important thing is for you to prioritize your investigations. It is not cost effective as well as create a false alarm. It shows that you're not thinking enough. You just rely on your technology. Even the MRI is done. So what? You still need to interpret on case by case basis. Let's say patient has pruritus, itchiness, dark urine and pills. So all these are suggestive for cholestasis. Okay, so next plan is what? What do you want to do? Especially you want to look at the bilirubin, kan? What the total bilirubin as well as the direct ones, as well as you do a urine, and then you look at the ultrasound to look for the obstructive causes of jaundice. This is how you look. Don't forget there are also autoimmune causes of cholestasis. Later on when you go back and read, so you will know what kind of autoimmune diseases that can affect the liver, especially when you do AMA and LKM antibody. Okay? All these are autoimmune. You're not expected to know about this, but you should know the basic things. Yeah, what are they suggesting? Let's say this patient, oh mak saya, sorry. Let's say this patient is female and in 40s, a little bit fat. They keep on complaining right-sided hypochondriac pain, like macam gastric, sharp pain after they eat food. So what you do, you suspect gallstone disease, yeah, cholelithiasis. If they have a fever with the pain, so you suspect this patient will have cholangitis, yeah, ascending cholangitis or cystitis with cholelithiasis, yeah, things like that. The terms is interchangeable, but the most important thing is the basic underlying etiology, right? So let's say you have a patient with progressive jaundice, painless. This patient is not complaining of any pain, but the patient probably has a palpable mass, a palpable gallbladder. Patient looks jaundice, chronic constitutional symptom. The weight is, the weight is getting down and down and down. This patient has marked anorexia and palpations. You can feel something hard on the right hypochondriac region. That suggests that this is the enlargement of the gallbladder. It's possible cholangiocarcinoma, but it can also denote that the patient might have a pancreatic CA because of the obstructive effect. Okay? Alright, so we have a famous trial, yeah? Charcot's trial. You have progressive jaundice, fever and chills. So this is ascending cholangitis in medical emergency or surgical emergency. Okay, so this is combination medical. You can always refer to surgical. Okay. Alright. Next, hematemesis, easy bruising, mental confusion, yeah, which might suggest this patient has hepatic encephalopathy in chronic liver disease. You should not miss these signs. Right. So what are the investigations indication? Okay, not all patients will want to do all these tests. It depends on per patient basis. So you have to select which are the best investigation that might help you in arriving at the diagnosis. So you look at the FBC. Okay, especially you want to look out for hemolytic, you want to look at the anemia, degree of anemia, you want to look for the leukocyte count, whether it's marked leukocytosis or leukopenia, that might suggest certain things. Okay, and then hemolysis, what do you expect? What do you expect in FBC? Okay, anemia. What kind of anemia? Okay, they can have a normocytic normochromic, but if it's too massive hemolysis and then it's chronic, so what will happen? The RBM, the red bone marrow, cannot compensate with the degree of anemia, so what will happen? They will have a macrocytic anemia. So it can tell us, yeah, it can give us a clue. Okay, probably you can tell whether this hemolysis is ongoing for some time or whether this is acute hemolysis. You can tell, right? How about liver biochemistry? Like I said, you have to interpret per case basis. Yeah. What if the gamma GT is more increased than the AST? What does it suggest? AST is more elevated than the ALT. So what does it suggest? Yeah. The ALP is more than the AST and ALT. So what does it suggest? Okay. Right. And then you look at the bilirubin. Like I said, how do you differentiate with it? What are the possible causes of direct hyperbilirubinemia and indirect hyperbilirubinemia? Keeping in mind that sometimes certain patients mixed picture can occur concurrent. Yeah? And then when you do a certain things, when you suspect viral hepatitis, viral etiology, so you want to confirm whether this patient truly has a viral hepatitis or not. So you check the serology and the antibody of the patients, kan? Right? Don't forget, sometimes patients with hepatitis B and C, they have co-infection with HIV. So you want to check for HIV antibody as well. Okay? Don't forget. Yeah? Alright? Because of the high risk that they have. Okay. What does the alpha fetoprotein tell you? Yes, carcinoma. Especially the hepatocellular carcinoma. But in certain cases, germ cell tumor, that can also be raised because all these are primitive tumor. Right? Albumin is very, very important, especially in patients with chronic liver disease. It's a prognostic marker. Okay, one, it just tells you how's the nutrition of the patient. Okay, let's say generally, how the patient is eating. Okay, the exogenous protein. Okay, and that reflects the albumin. But more importantly, is the endogenous process of the patient's liver synthesis. It just tells you the synthetic process of the liver. Let's say this patient is in liver failure, the albumin will not be produced. Hypoalbuminemia will be present. So the degree of hypoalbuminemia also is a prognosis too. Prognosis, it can tell you whether this patient is going to be good or bad. Especially when the patient has hepatic encephalopathy, chronic liver disease, patient in respiratory distress as well. A patient with pneumonia, also albumin also is a good indicator. To tell whether this patient is going to survive more than the patient with normal albumin or not. Yeah? Patient with septic shock, critically ill patients, also we rely on albumin level. Because many studies have studied the degree of correlation of albumin with the outcome, the mortality of the patient. So they found out that the albumin, the lower the albumin, those patients in ICU with septic shock or multi-organ failure, so those with lower albumin, prognosis is worse than the slightly higher albumin level. Okay, just remember that. Okay, and then there's also a good and sensitive test for your synthetic liver function, prothrombin time, in chronic liver disease. This is part and parcel of your criteria used for prognosticating as well as stratifying patients with chronic liver disease. Okay. And like I mentioned, ALT, AST, ALT, gamma GT, all those things, you have to know what are the indications for. Okay. Alright. So these are the approach. How would you like to investigate a patient? Based on your history. Based on the history. You don't do everything. You don't do everything in the box, but based on your patient. Okay? And then, of course, you want to confirm your etiology, whether sometimes you don't need imaging to confirm whether there's any viral hepatitis or not. Sometimes it's just non-specific. It's just macam like mildly raised ecotexture of the liver in viral hepatitis. But sometimes we need to know whether the viral hepatitis has progressed to become a cirrhosis or liver cancer. That's why you order for imaging. Alright? So, but basically ultrasound imaging you do to look for any obstruction. Look at the bowel, hepatobiliary structures, gross ones. If you suspect this patient has ascending cholangitis, of course you want to look for a stone. And you want to look at the gallbladder, whether the wall is thick or not, whether there's any polycystic collections or not. That might suggest this patient might have an acute inflammation of the gallbladder, or if there's any empyema pus around the gallbladder. So you want to confirm that. Ultrasound is a good and sensitive imaging tool, rapid ones. You don't need a CT to do that. It is very quick, rapid. It doesn't need to for you to inject a contrast. Okay, and then there are other modalities as well you can use to investigate a patient with the GI system. You can do a CT scan, especially looking for abdominal mass, abdominal malignancy, abdominal contusion. bear in mind, sometimes CT scan is superior than ultrasound, but there are a few rare causes where ultrasound is much superior than CT scan, especially in gallbladder disease. Ultrasound is much better than the CT scan. That's why we prefer ultrasound rather than CT. Okay, but CT is helpful, especially in patient you want to look at the degree of the fluid. Yeah, sometimes in ultrasound you cannot see because of the bowel obstruction. Because of the bowel air shadow. Yeah, bowel shadow or the fluid. The fluid interfere with the findings. So you would need to do a CT scan for that. Okay, anyone heard about endoscopy? Okay, the usual one is OGDS. Okay, why you do OGDS? Yeah, it's upper, esophageal, gastro, duodenal scope. Okay, as the name implies, you want to look at any direct visualization of any abnormalities in that area, that region until the duodenum. Okay, it's very, very helpful, especially in patient with upper GI bleed. Okay, it is both therapeutic as well as diagnostic. Maksudnya you can do a rapid visual diagnosis, yeah, whether this patient is bleeding, whether the bleeding is because of spurting vessel or because of an ulcer, a massive ulcer or very small spot ulcer. You can tell that right away, and then you can do something on it. So it's both diagnostic and therapeutic. But when you extend it further, the OGDS, extend it beyond the duodenum and you go back into the ampulla obvata, go back slightly into the common bile duct, so it becomes a ERCP, especially important in patients with gallstone disease. Okay, alright, this is where your gallstone disease is being managed by surgeons or our gastroenterologist. Okay. How about EUS? Where's EUS? This is a picture of EUS. Basically, it's just a scope, but it's enhanced endoscopic ultrasound. So maksudnya, you do both scope and ultrasound. You pass through a scope as well as you do a trans-abdominal ultrasound, and you locate via this concurrent images to look, especially at the pancreatic region. Okay, pancreas is retroperitoneal. Yeah, you cannot see only by OGDS. You cannot tell. Yeah, but if you suspect this patient has a small stone, or this patient is because of the obstruction because of the somewhere retroperitoneally, so this modalities is helpful. Or sometimes when you do suspect this patient has lymphoma, gastric lymphoma, the mesenteric lymph nodes is enlarged. Yeah, before you do the CT scan, you can try EUS. It gives you a lot of information. It is both diagnostic as well as therapeutic. Yeah, more of diagnostic procedures. Okay, and then sometimes even if you suspect a mass, then you can do a biopsy straight away from EUS. Okay, and how about capsule endoscopy? This is the one, small capsule, has a very micro camera inside it. So it is very useful where you cannot perform your normal OGDS, where you suspect this patient has GI bleeding somewhere, this patient keep on losing blood. You do OGDS is quite normal. You do a lower scope is quite normal. So where are the areas that you might miss? The small intestines, yes. So small intestine is very rich in vascular regions because sometimes it might bleed from the small mesenteric arteries. So you can tell, yeah. Sometimes there's a possible bleeding just by asking this patient to do a capsule endoscopy. It is helpful in certain cases, but note with the technology, yeah, because of the small size, it needs a lot of expertise to interpret. So it is very costly to do this. That's not suitable for all patients. Okay. So similarly, what is the approach for you to do when a patient presented with jaundice scan? Okay, you look at the patient's direct and indirect things. Yeah? Look at the ELP, look at the AST, and what are the possible causes. Okay, And then if the AST, ALT is more markedly elevated than the ALT, so what could be the possible causes? How are you going to screen this patient further? But, like I said, it's very important to correlate with your history. Do not just base on this chart, based on your patient. Okay. How about virus? Just a recap. I'm sure you must have gone through about microbiology, microbiology topics. Yeah? So hepatitis C infection is what? Is it what kind of virus? Is it RNA, DNA? It's RNA virus. So you know how is it being transmitted? Okay, body piercing, blood transfusion. Yeah, it's very important class. As well as vertical transmission, mother to baby transmission. This one is notorious. A very minute isolated cases has been reported whereby this patient has Hep C and HIV just by doing a manicure. So they share the same when they detect this case and they trace the genome of the virus. Is the same as the punya cousins. The cousins gene, sama, the identical virus. So it's postulated that this patient probably shares some manicure sets, and apparently the cousin is later diagnosed to be HIV as well as hepatitis C. So just be careful. You never know what you are getting. That's why when you go into clinical works, protect yourself above others. If you cannot protect yourself, how are you going to protect your other colleagues or your patients? Okay. Alright, so what's the importance of HCV infections? Okay, look at this. After exposure, about 15% will convert. Okay, resolve. They can get back to normal state. But most of the cases that we see, they become a chronic state. They become a chronic hepatitis C. Okay, whether it's infected ataupun just carrier. Alright, so they can be stable. They can be sometimes with flare, which is rare. Yeah, but eventually, what happens if the chronicity persists, and then it will lead to cirrhosis and eventually a hepatocellular carcinoma. Okay. Right, so you have to know there are a few genotypes and the treatment is based on genotypes. You aim for cure by right, but potentially at this point of time, hepatitis C is, at the moment there's no 100% cure yet, but it's a potentially cure. Potentially cure maksudnya ada 1 or 2 cases in the whole world, this patient is totally, we eliminate the hepatitis C after a rigid treatment. Yeah. But we never know which one patient will respond to treatment. Yeah. So the best thing is you follow the guidelines. Okay, how about hepatitis B? It's DNA virus. Okay. Whether it's what are the significance of looking at the core, looking at the surface antigen, look at the E antigen. So you have to know. Yeah, this is the very important concept, especially in hepatitis B. Okay, kalau let's say, how do you diagnose this patient has hepatitis B? So you look at the surface antigen. Okay, and then what does the core tell you? What does the E tell you? E antigen tells you. Sometimes this patient hepatitis BS negative, hepatitis BS positive, but E antigen is negative. E antigen is not there. So this is very tricky, especially when we want to treat this patient later on. So we call that pre-commutant virus. So you have to know the basic molecular organization of the hepatitis B. And then sama juga kalau let's say the similar, we ask you to interpret blood investigations. Okay, HBs AG positive, HBs antibody is negative. So what does that mean? If it's HBsAg negative, HBs antibody is positive. So what does that mean? Okay, sometimes you might just get confused, but please know the basic understanding of the molecular organization of HBV. Alright, like you see, you can look into your, you can see here, this is the area where your hepatitis B predominates, okay, especially in the Africa, the Southeast Asia, as well as the Central Asia, where Malaysia stands also in the high prevalence area. Look at America, look at Europe here. Look at America and look at Europe here. They have very, very low prevalence of hepatitis B. Kalau ada pun probably because of migration factors or foreign workers and things like that. Yeah. And again, the causes of hepatitis B, because of the high-risk behavior, injecting needles, sharing things, sharing all those things with the contact with body fluid. Okay, hepatitis B is not being transmitted with what? Do you get hepatitis B by sharing spoons and forks? No. Yeah. But just be careful. Sometimes when you shave, you might shave, go to the barbers, please ask for a replaceable cartridge. Yeah. Sama juga when you do a circumcision, anything that might involve a single drop of body fluid. Okay, it's potentially transmittable. Okay, so this is a very important graph for you to know and keep in mind forever. Okay, what does the HBe antigen carries? The antibody, IgF, and the HBsAg titer. What is the duration? What is the incubation time? Yeah, how long does it manifest before the symptoms? So you have to correlate with all these markers. Alright. Like I said, in clinical years, these are important terms. Immune tolerant, whether you're immunoactive or inactive, based on your viral loads, whether your loads is very, very high, and the degree of your ALT, because the treatment of hepatitis B is based on your viral load as well as the AL. Okay. And compare the histology of the gross histology of your liver. Normal liver, what happens to the fatty? Sometimes it can get big, but later on it can get shrunken. And remember, it is also a known, recognizable cause of chronic liver disease nowadays, where we call that non-alcoholic fatty liver disease, NASH. Previously known as NASH, non-alcoholic steatohepatitis, is also potentially one of the cause of progression to liver cirrhosis as well as hepatocellular carcinoma. So if you suspect, you do a lipid profile for this patient, you got a patient with high lipid profile, you need to address that issue, treat the patient well, because fat is also dangerous to the liver. It creates all the oxidation process, and then all the inflammation, the degree of fibrosis and things like that. Later on, this patient eventually can have cirrhosis as well as hepatocellular carcinoma. Same, okay. And then these are the patients with liver cirrhosis. Microstructurally, it's distorted, nodular. This is as a general rule, alcoholic liver cirrhosis on clinical examination, you can still palpate the liver. The liver is enlarged. But in advanced liver cirrhosis of viral hepatitis, usually the liver is shrunk. Okay, that's as a general rule. But there's always exception to the rule. Okay, these are the treatment for hepatitis B. Okay, you give lamivudine. And then there's also monoclonal antibodies here, second line therapies here, PEG interferon pegasus is also for Hep C, co-infection as antica. Right. How about hepatitis A? Does hepatitis A becomes chronic? No. Usually it becomes fulminant, or the patient might resolve. The patient is cured. Okay. But look at the prevalence of hepatitis A viral infections. Okay, partly because of genetic. Don't blame the hygienes. Yeah, sometimes partly because of the genetic, of the virus, genetic of predisposition of the patients, the populations. They are more prone to get a certain virus than others. Okay. And then there are also some association of viral hepatitis A with certain non-liver manifestation. Yeah? Apart from the patient might become jaundice, unwell, nausea, vomiting, epigastric pain or things like that. They can have also dermatologic manifestation, which is cutaneous vasculitis because of the immunological phenomenon. Okay, and then sometimes very bad, hepatitis A fulminant, they can have a hemolytic anemia, thrombocytopenia, because of consumptive platelets. Renal, they can have glomerulonephritis. Okay, GI, they can have, or association with pancreatitis, where the sepsis is very, very bad, If it activates your inflammatory markers, especially attack the vulnerable organs, which is the pancreas, go haywire because of the SIRS process, systemic inflammatory response syndrome, or CARS syndrome, counter anti-inflammatory response syndrome. Okay, and then they can also have myocarditis or neurologic hepatitis A. So a few case report has reported that the association of hepatitis A with Guillain-Barré syndrome, which has suddenly become weak, unable to move the lower limbs. And when you do a clinical examination, the patient is flaccid and areflexic. The power is 0, but the tone is low and there's no reflexes. So the problem is at the spinal cord or the anterior horns. Okay. How about chronic liver disease? This takes up a chunk of our patients in hospitals. Because of the name implies, the chronic liver disease, sometimes the patient comes in and out of the hospital. Sama juga macam chronic heart failure, macam diabetes, macam ada all chronic illness. Okay, it's very, very very consuming. But if you can treat the patient well, you can help to prolong the patient's morbidity and mortality of the patients. You help them to improve their quality of life. Okay? Okay, what are the symptoms of chronic liver disease that you know? What are the symptoms? They can just complain of bloatedness because of the fluid in the abdomen. They can symptoms of fluid retention, edema lah, muka pila, sacral edema. They become very, very bloated. They can tell you that. Abdominal pain because of the abdominal swelling is so large. Sometimes it can get painful. Okay, and then the patient becomes, anorexia, weight loss, oral appetite is very, very low. So all these are vague symptoms, but you have to correlate the patient's clinical. Okay. What else? Because of the renal vasoconstriction, sometimes they might get hepatorenal syndrome at advanced stage. The renal might be affected because of vasoconstriction, so they might complain of reduced urine output. That's later, But they also notice that the patient becomes, the skin becomes easily bruised, things like that. Okay, mild jaundice. Sometimes the patient doesn't have jaundice, but mild, they don't notice. Probably the family members notice this patient. Okay, so go back and read about the underlying pathophysiology of chronic liver disease. It's very important for you to carry this concept. What are the mechanism of ascites? How does this patient has gynecomastia? Why does this patient has ascites? Why does this patient has bleeding edema? Okay? Alright, all these concepts you need to know. Okay, of course, what happens when this patient has chronic liver disease? There's some degree of portal hypertension that's going on because of the splenic vasoconstriction. Okay? Alright, so what are the consequences? So you have ascites, you have the portosystemic shunts, not only in the varices, you have other areas of shunts. Dekat mana? Gastric varices. When you do a scope, sometimes you can see a varices, a fundal varices. Okay? And then hemorrhoids is also manifestations, but very, very rare because it's down there. Even patients with no chronic liver disease also have hemorrhoids. But where else photosystemic shunt can happen? Retroperitoneum as well as abdominal wall. This is a favorite surgeon's question. Okay, when you go to your surgical posting, please remember, whereas your photosystemic shunts happen apart from your varices, esophageal varices, whereas your photosystemic shunts. Okay, and then as a consequence of portal hypertension, the splenic vasoconstriction, what happens there? There will be a degree of splenomegaly. Okay, and then of course, this patient, because of the liver dysfunction, they can have a hepatic encephalopathy. Alright? Alright. So, what do we mean by portal gastropathy? When you do a scope, yeah, there will be some pattern, in the underlying gastric mucosa because of the increase in your pressure. So you can have a mosaic pattern, yeah, and then some cherry spots and things like that, yeah. And then you look at the funnel. When you do OGDS, you go from the esophagus to the stomach, and then you go back. You naik atas sikit to look at the fundus because of the nature of the curvature of the gastric structure. Yeah. And then you look at that. Sometimes the varices will happen there at the fundus area. Okay. This is a common scenario in what? Okay, common scenario, especially with patient with ascites. So how do you do that? You go to your clinical years, yeah, to know. But the basic indications, you need to know why you do a certain things. Yeah, why you do that? You want to differentiate a patient with ascites, whether this is transudative or exudative. And let's say you know this patient already has a chronic liver disease, you suspect this patient has an infection on board. We call that spontaneous bacterial peritonitis. So we need to get evidence for that. Yeah, based on clinical suspicion. Okay, probably this patient has fever, little bit of abdominal pain and diarrhea, but it could be also because of some AGE. You want to confirm whether this is truly from spontaneous bacterial peritonitis on board. That's why you do a peritoneal tap. Yeah. But basically, you want to go for etiology. You want to look at what are the causes. You want to confirm whether the portal hypertension is there or not. Yes, so from your ascites fluid, you know this patient has some degree of portal hypertension just based on your ascitic fluid. Okay, have you heard about the tips? Okay, this is need a surgical expertise, yeah, where you when there's vasoconstriction, so you would by right, you want to reduce the pressure. So, you masuk balloon and you dilate the vessel. Sama juga, if you have a myocardial infarction, there's a block in your coronary arteries, you do a balloon angioplasty plus stent, PCI. Kan, you insert a wire and then dilate as well as keeping the vessel open by putting a stent. So, this is a similar principle. Okay, the approach is slightly different. Probably this one is from the arterial, probably this one is from the jugular, depending on your procedure. Okay, but what are the complications of PIPSS? You need to go back and check. Yeah, not all procedures are, 100% safe. It carries a certain risk. So, what are the expected complications of TIPS? Sometimes it might exacerbate this patient to have a hepatic encephalopathy further on. So we need to stabilize this patient first. Check whether the electrolyte is okay, this is glucose, the patient is okay, there's no infection on board, then you can do a TIPS. If the infection is not controlled, there's no point you do this. Yeah, it just aggravates these patients further. Okay, how about peptic ulcer disease? Okay, this is a big topic, yeah, in a surgical as well as medical. We can manage peptic ulcer, surgical also can manage peptic ulcer. The advantages of surgical over physician is that open up in patients with refractory upper GI bleed. Let's say it cannot control by scope, so you need to cross-refer to surgeon and do some emergency procedure to secure the bleeding. Yeah. Alright, so it has been found that H. pylori is being implicated in many cases of peptic ulcer disease. Okay, Apart from that, of course, you have so many other risk factors. Let's say you take NSAIDs, sakit kepala sikit dah nak makan ibuprofen lah, Voltaren, which is not recommendable. It's harmful to your gastric mucosa, and it's also harmful to your kidneys. So do not take every medications lightly. Other causes of fatty acid disease are very, very rare ones in association with, hypergastrenemia. You go back and look what are the causes of hypergastrenemia. Some of the tumors can secrete more gastrin than others. Zollinger-Ellison syndrome. Have you heard about Zollinger? Sometimes it can be implicated in causing fatty acid disease. Some mucosa associated lymphoma also has been associated with peptic ulcer disease. Hypercalcemia is also associated with peptic ulcer disease because it just alter your mucosa lining. Okay, so there are so many factors. Alcohol is one of it. Smoking is one of it. Okay, I'm looking at the boys because prevention is better than cure, right? And about more than 70% of Malaysian guys, not Malaysian women, I'm not sure about Malaysian women because there's no study, but it has been found that more than 70% of Malaysian guys smoke. It doesn't matter how heavy you smoke. And we have no actual definition for whether this is light cigarette smoker or heavy cigarette smoker. If you smoke, you smoke. Okay? Alright. There's also some genetic predisposition, cancer, chemotherapy, hypercalcemia, like I said. Okay? Physiological stress is contributory, but it has been linked, postulated, but there's no actually, when we do a certain patient, we look at the patients whether they are stressful and compare with non-stress, we cannot really identify where's the exact point. But we found a little bit of more prevalence in patients with stressful conditions they cannot manage. We probably postulated that because of the hyper secretion of that gastric fluids. Okay, type A personalities, all this in the rat race, as well as a certain disease. All these are contributory to patients with fatty ulcer disease. Okay, curling ulcer, common in patients with in ICU, curling ulcer. Because of the patient is stressed, not because of stress emotionally, but the body is undergoing a massive physiological stress. All the systemic inflammatory reaction is a big activator, all the chemokines is being attracted to that place. So they have potential to get us curling ulcers. So prevention in all ICU patients is very, very important. Alright, corticosteroids, don't forget. What do they do to your prostaglandin, your COX? Alright. So this bug, H. pylori, you go back and check. What are these bugs? It has been implicated. So far, it's well known, associated with PUD, peptic ulcer disease. Maybe because of the PUD is not only ulcer, but it can also comprise of mild reflux, dyspepsia, gastric ulcer, duodenal ulcer, lymphoma. It's been also implicated with H. pylori. Alzheimer's nowadays also been implicated with H. pylori. So you need to eradicate this bug. Okay. Once you do OGDS, you found H. pylori present, eradicate this bug. Okay. And these are the pathogenesis on how does it happen. Local factors as well as distant factors. Okay. From studies, they have found that in hospitalized patients, what are the common causes of upper GI bleeding? Look at that. Esophagitis comprise about 20, but GU erosions takes up the bigger chunk. Okay. How about GU alone and DU alone and other causes? Okay, probably because of the stress in ICU, stress ulcer, and no source has been created. Probably there's not enough data. It's not that no source found, but probably we don't have enough data to implicate where the cause of the GI bleeding. Okay, sometimes uremia can cause a GI bleeding, but it's very, very small occult bleeding. So sometimes the lesion you cannot really identify, but the patient is keep losing blood. Okay. Alright. From a rubric data, So what are the causes of non-variceal upper GI bleeding? Of course, when the patient is presented with massive upper GI bleed, it's better being managed by surgical. Yeah, because anything happens, they can just go straight and open up this patient to secure the hemostasis. But what happened? Let's say this patient is, probably is PUD origin. So what are the causes of non-variceal upper GI bleeding? So you can attribute that to, okay, of course lah, ni number one, yeah. Common are still common. Remember, PUD is still number one cause of upper GI bleed. Apart from that, what are the other things? Probably some esophagitis, yeah, erosions, mallory was there, yeah. Barrett's also sometimes they come with a mild bleeding, yeah, upper GI, but it's not really significant, and other cause. Okay. Similarly, same. And when you have a patient with upper GI bleed, so how do we know that this patient is going to fare better than others? So these are the risk factors or the outcome of what factors that affects the outcome of patient with upper GI bleeds. The older they are, of course, the prognosis is not better than the younger ones. Okay, age is an important factor in so many other cases as well. If there is any comorbids, let's say you compare normal dengan a patient with end-stage renal disease, which one you expect it to heal better? So of course the normal ones and with no comorbids, yeah. And then let's say this patient has with hypotensive shock, yeah, the degree of bleeding is massive, the outcome is slightly lower than the patient with no hypotensive. So these are the clinical indicators, yeah. And then whether this patient has underlying coagulopathy, yeah. Sometimes with the patient with warfarin, yeah, sometimes they can just get an internal bleeding when they are over warfarinized. Okay, and then rebleed from the same lesion. This is also important factors, especially to a gastroenterologist point of view. So, how do we classify? There are a few classifications. Yeah, whether this patient has a chance to rebleed in the same hospital admission or not. You look at the OGDS, kan? Look at the lesions. How big the lesion is, whether the vessel is visible or not, what are the ulcer is clean or with clots, adherence clots, whether the vessel is spurting out. All this gives a certain prognostic markers. Alright, so we love to ask you in clinical years, how do you manage a patient with upper GI bleed? It's a very, very important concept. Yeah, if you know how to manage a patient with hypovolemic shock, yeah, you know how to manage a patient with upper GI bleed. It's about the same. If the patient is bleeding, so what you should do, yeah? This is part and parcel of your clinical medicine. So you need to know how to resuscitate a patient with upper GI bleed. Secure at least 2 granulas, yeah, or secure the breathing and circulations, and check vital signs. Yeah, if the patient is a little bit hypoxic or tachypneic, you would expect the patient when you have a hypovolemic shock, what happens to your curve, oxygen dissociation curve will be shifted. Kan? You tak nak lactate acidosis, you want to prevent that, and then it's also the patient is rendered hypoxia, so you give oxygen. Kan? You insert CBD to monitor urine output, and you give colloids to maintain the pressure. You give crystalloids. Which one? Crystalloid and colloids. That one is a big issue when it comes to your clinical years. Okay. Later on, albumin is indicated in patient with hypovolemic shock. That one you will learn in clinical years. Okay, but how to resuscitate patient is very important. Yeah. The most important thing is for blood transfusion. In a patient with bleeding, so you would like to normalize the hemoglobin back. You try to normalize the hemoglobin. That's why you give patients blood, XL. In patient hemodynamically stable, you give XL. In hemodynamically unstable, you are allowed to give a whole blood. So why we prefer certain things over another, then you come into your clinical practice later on, because whole blood cell carries certain things, that one you will learn later. Okay? In the patient with varices bleeding, we used to do this. We used to insert a sense-taken Blakemore tube. Okay, so this tube, it has 3 ports. It has one single catheter, but it has a esophageal as well as the stomach funnel balloon. Okay, This one is for the esophageal. This one is for the stomach bundle balloon. So you just try to keep on inflated as a bridging therapy. Yeah, this is not the exact mechanism management for patient with varicose hemorrhage, because it can be rapid. This patient might deteriorate fast, so you need to get these patients banded as soon as possible. But if you work in the hospital, district hospital, where surgeon is, you have to transport this patient, this is a bridging therapy. Maksudnya you buy time to save the patient's life. You go all means to save the patient. Okay, what does the patient with massive upper GI bleed? Sometimes they can tell you that the stool consistency is black tari, macam colour tar, yeah. But most of the patients with upper GI bleed don't have this black tari stool, yeah. So you just bear in mind. If you have a suspicion, just go refer to gastro or surgeon, yeah, to do a OGDS. It's both diagnostic and therapeutic. Of course, when you have the patient with like this black tari stool, you know the bleeding is massive. Yeah, this is altered blood already. So this patient has been losing some degree of blood already. Yeah, but if the patient, they complain of a little bit of hematemesis, but the blood is not tari, do not just totally ignore this patient. Probably, have to confirm whether this patient totally have upper GI or not. You have to confirm. Do not totally ignore patient's symptoms. And this is the picture of patients with with a peptic ulcer disease. Okay, like I said, when you have a H. pylori, you need to eradicate it. Yeah, there are the triple therapy, there are quadruple therapy. So this one you learn in your clinical years. Okay, other lesions that can be identified on OGDS, like indolent T-cell lymphoma. This is proven by biopsy. Yeah, it looks like polyps, but actually when you biopsy, it turns out to be a lymphoma. From OGDS alone, you cannot tell whether this is cancerous or benign or some. Yes, you can tell whether this looks like a malignant lesions or benign lesions, but most of the time you still need a HPE confirmation. How about Barrett's esophagus, esophagitis, as well as extensive candidiasis, esophageal candidiasis. You would expect this patient in immunocompromised patient before and after methylene blue stain. Right. Don't forget, in GIT disease, there is also skin manifestation which is associated with GI. Yeah, Kaposi sarcoma. Kaposi sarcoma is linked with what condition? What's Kaposi's lesion? This one. Yeah, purplish macules on the tongue, on the buccal, yeah, on the palate. So it has been indicated in what? HIV patient. EBV. Yeah? EBV patient. Peutz-Jeghers syndrome. Yeah? They can have these lesions. Yeah? Hypopigmented lips. Yeah? This is not bleeding. But they have a certain kinds of macam vasculitic lesions on the lips, as well as in the buccal areas. And then when you look at the intestine, it's not normal. So that's Peutz-Jeghers syndrome. Okay, and then a little bit on microbiota and infective diarrhea. You have so many gut floras. When you alter the immune, your gut flora punya surrounding, you render them to have symptoms. Yeah. Okay. So the concept is whether this is acute diarrhea or chronic diarrhea. Yeah, you have to distinguish whether this is acute diarrhea. If it's acute, is it infective or non-infective causes? Because infective you have to treat. Non-infective, there are a few other causes that you need to elucidate. Okay. How about persistent diarrhea, chronic diarrhea? So what could be the possible causes? Chronic pancreatitis is one of it. Some of them come with a very marked constipation symptoms, more of systemic symptoms. Yeah. Inflammatory bowel disease. Yeah. You see Crohn's disease. Yeah. Ulcerative colitis. Yeah. IBD patients. And a patient with HIV positive, retroviral disease. In clinical, we call them retroviral positive, not HIV positive. Just because of the the professional and ethics involved in the patients being called HIV positive. When you talk in conference, that's okay, you can say, but during ward rounds or during discussion, you would prefer a retroviral disease state rather than HIV. So they can have all opportunistic infections, or the microspora, the MAC, they can have a chronic diarrhea. So you need to exclude this out. Okay? And then of course, there are a few types of diarrhea, whether this is secretory, and whether this is inflammatory, whether this is fat, or it's just pure osmotic diarrhea. And the cause is different. Okay? And this is in opportunistic infections in HIV. You might come into contact very once in a while, but if you do elective posting in infectious disease, yes, you may heard these terms quite often. Yeah? MAC, microsporidiosis, crypto, CMV also can cause chronic diarrhea in patients with retroviral, things like that. And don't forget, because of the extensive use of antibiotics in the hospital,